who exactly are girls or women with perinatally acquired HIV today? If we take a look back in history and look at the pediatric HIV epidemic, worldwide, you can see that the first perinatal new infections in pediatric populations started occurring around 1985, with a peak sort of around 2000 to 2005, followed by a really rapid decline, which coincided in 2004 with the introduction of combination ART for the pediatric population in most of sub-Saharan Africa. In the US, though, this peak and decline actually occurred about a decade earlier. So in the US, this height of new pediatric infections occurred probably around 1989, 1991, followed by the same rapid decline, which corresponded to, in 1998, about the time when PI-based combination ART was recommended for treatment. If we take a look then at this 1985 year and consider those are the first pediatric infected, perinatally infected kids, and we fast forward to today, that would put these kids around the age of 30, 32. And if you take the kids that were born, say, around this peak area in 1991, and you fast forward to today, that actually puts them around the age of 26 to 27. But, understanding how old they are and where they fit in the pediatric HIV epidemic is really just one part of the story. The big question is, well, what makes these pregnant women with perinatal HIV so special, and why devote an entire session to this? I have a few thoughts. I think women with perinatal HIV have lifelong immunosuppression, and as such, this may alter their immunologic functioning over time. They may have perturbed inflammatory responses, which could impact the in utero inflammatory environment of their fetuses. Like long-term survivors of chronic disease, these women have probably unique psychosocial stressors that could complicate their ability to navigate the HIV adult healthcare world, to transition to HIV adult care, and even to navigate obstetric care if they get pregnant. So keeping those things in mind, what I want to try to do for us today is unravel the potential impact of maternal perinatal HIV infection on the entire spectrum of maternal health, spanning from the preconception period here through pregnancy and into parts of the postpartum period. I'd like to touch a little bit on the reproductive health in adolescents with perinatal HIV. We'll look a little bit at maternal health during pregnancy in these women, vertical transmission rates, pregnancy outcomes, and lastly, we'll take a look at some new data, though it's scant, on early infant outcomes of infants that were actually born to pregnant women with perinatal HIV. So let's start with reproductive health. Couple of questions we want to ask as we think about reproductive health in adolescents with perinatal infection. How many of them are sexually active? What are rates of genital infections and abnormal cervical cytology? How many of them are getting pregnant these days? And also, related to that, what's the status of their reproductive knowledge and behaviors? Well, the PEDS ACTG 219 trial was a huge trial that has enrolled only perinatally infected children. And Susan Broglie et al. Did this nice analysis where they looked at 638 girls who were all perinatally infected in 219C, also all at least 13 years old or older, and they found that about 27% of these adolescents with perinatal HIV were sexually active. And what did these sexually active perinatally infected adolescents look like? Well, they tended to have higher viral loads, lower CD4 percentages than their non-sexually active counterparts, and unfortunately, a lower proportion of the perinatally HIV infected adolescents actually even reported being on ART. How about sexually transmitted infections in this group of adolescents with perinatal HIV? Well, they found rates of about 12% condyloma, trichomoniasis was about 9%, and chlamydia was 9% as well. But I wanted to put this in a context for you because if you compare these rates with rates of STIs in a non-perinatally infected cohort, which I have here, the REACH cohort, you'll see that the women with perinatal infection actually had lower rates of STIs. How about cervical cytology? Well, of the 174 sexually active adolescents in 219C who are all perinatally infected, only 58% of them actually had a documented cervical pap smear. And of that 58%, a third actually had abnormal cervical cytology at their first exam, which mostly was made up of ascus, followed by 30% low-grade squamous intraepithelial lesions, and then the last bit was about 10% high-grade lesions. Let's take that 30% of abnormal cervical cytology in our perinatally infected adolescents and also contextualize that for you. So I have here in the green bar adolescents with perinatal HIV infection. 30% had abnormal cervical cytology. But compare that with these yellow bars, which are actually HIV uninfected adolescents in large cohorts. This first yellow bar represents a cohort in Montreal of 18 to 24-year-olds who were HIV uninfected adolescents. And then this cohort here is from the multinational Patricia trial, which evaluated abnormal HPV and cervical cytology. So you can see the perinatally infected adolescents did have higher rates of abnormal cervical cytology. But if you compare those with the non-perinatally HIV-infected adolescents in the US legacy cohort, they actually have lower rates of abnormal cervical cytology. Let's take a deeper dive into the legacy cohort, because the legacy cohort is very unique. It consisted of HIV-infected adolescent females, and this analysis was only of the females. But they had a nice mix of adolescents with perinatal and adolescents with non-perinatal HIV infection. So they were able to look at the likelihood of having received a cervical pap smear at all. And what they found was that if you were perinatally infected, lower proportions of the perinatally infected adolescents actually had a cervical screening done. And these are all sexually active adolescents. And when they controlled for and adjusted for confounders, that relationship remained the same. I think this is interesting, and it's somewhat concerning because, as many of us know, the Icahn recommendations currently are that in HIV-infected women, cervical pap screening should begin either at the age of 21 or within 1 year of becoming sexually active, whichever comes first. How about pregnancy? How many of these perinatally infected adolescents are becoming pregnant? Well, in 219C, the overall incidence of pregnancy was about 33.5 per 1,000, which actually isn't too much different from the overall incidence of pregnancy in the US amongst that same age group of 15 to 19-year-olds in 1999, which was like 39.1 per 1,000. Despite that, we do see over time trends where pregnancy rates in women with perinatal infection are rising, and that's where you see this purple bar slowly, steadily increasing since 1996 to 2013. This is data from a combined analysis of the FACT-SMART study and the Impact 1025 protocol. Our French colleagues have actually found similar trends as well. And you can see in their recent abstract at CROI, again, steadily increasing rates of pregnancy between 2006 to 2014 in their women with perinatal HIV infection. It's interesting, though, even with this increasing rates of pregnancy, this small study that was just published last year actually reported that perinatally infected HIV women had less likelihood of actually discussing how to prevent pregnancy with their healthcare provider. And though it didn't reach statistical significance, the women with perinatal infection also scored lower on their knowledge of safe conception practices. So let's recap just a bit then on reproductive health in women with perinatal infection. So one, sexual activity seems to be high among girls with perinatal HIV who are about 13 to 19 years old. The prevalence of abnormal cervical cytology in adolescents with perinatal HIV is lower than adolescents with non-perinatal HIV, but actually higher than HIV uninfected adolescents of the same age. Low rates of cervical cytology screening seem to be occurring in sexually active adolescents with perinatal HIV, and that's of some concern. And lastly, I think pregnancy rates are similar to those in the US amongst the same age group, but trends over time clearly show a steady rise in rates of pregnancy amongst women with perinatal infection. So we'll switch gears a little bit now and talk about maternal health during pregnancy in these women and vertical transmission rates. One of the earliest studies, and you guys will probably get sick of me talking about early studies in New York City, but that seems to be where a lot of these adolescents with perinatal infection have grown up and started having babies. So this was an early study done in New York City where they had 30 women with perinatal HIV who were pregnant, and they age matched them with 35 pregnant women with non-perinatal HIV. They evaluated these births, which occurred between 2000 to 2011, and reported an alarmingly increased rate of mortality postpartum in the women with perinatal HIV infection. In fact, there were 4 maternal deaths amongst women with PHIV within the first 4 years postpartum. Now, this is a small study, but a larger study that was done, this is data from our New York State Department of Health, which has a large perinatal surveillance registry which tracks all HIV-infected women and their HIV-exposed infants. Here we have data from 2005 to 2011 on all the births that occurred in that time period. And you see these different colored survival curves. And what we want to hone in on is this red survival curve, because obviously that one looks the worst. But that red curve represents the survival curve of women with perinatal HIV. And in further analyses, what they reported was that maternal perinatal HIV infection was associated with higher rates of mortality when you compared it with mortality rates postpartum in non-perinatally infected women. And this was whether you looked at it in US-born or non-US-born individuals, because in New York City we are a huge mecca for immigrants, so we decided to look at that stratification as well. But even doing that, the perinatally infected women had higher mortality rates. What about maternal HIV disease during pregnancy? For those of us who take care of these women, it's really no surprise some of the data that I'll show you on CD4 counts and viral loads during pregnancy and postpartum. This, again, is a small study, but out of New York City, where they looked at longitudinal CD4 in the pre-pregnancy, pregnancy, and 6-month postpartum period. And they compared this red line, which is the CD4 counts of women with perinatal HIV, with the blue line, which is the CD4 counts of non-perinatally infected HIV pregnant women. And of course, our perinatally infected women had persistently lower CD4 counts throughout pregnancy. In addition, viral load was persistently higher in women with perinatal HIV. And though both groups had a nice decline in their viral load during third trimester, which usually happens because, again, for those of us who take care of these women, pregnancy is a huge motivator to get your viral load down. And so both groups did decline and get lower at delivery, but you can see, at least with the naked eye test, that the women with perinatal HIV infection had or appeared to have a slightly steeper viral load rebound after delivery. Again, our French colleagues also found similarly high rates of viremia, and viremia being defined here as a viral load greater than 50 copies per mil during the first trimester and at delivery compared to non-perinatally infected pregnant women. Then in the US, again, I'll refer back to this study several times, but this, again, is the FACT-SMART and Impact 1025 combined analysis where there were 235 pregnant women with perinatal HIV compared to 2,035 pregnant women with non-perinatal HIV. And we also saw that the perinatally infected women tended to have lower CD4 counts in pregnancy, higher viral loads at delivery, and tended to be receiving an ART regimen that consisted of at least 3 or more classes of ARVs. So with this higher viremia and perhaps increased use of salvage-type regimens, it begs the question, are these women harboring more ART resistance? And this group out in Miami did a multinational study where they also matched perinatally infected with non-perinatally infected pregnant women and looked at differences in resistance patterns. And they found here statistically significant increases in ARV resistance and multi-class ARV resistance in pregnant women with perinatal HIV. Our Brazilian friends took a case series of about 22 pregnant women with perinatal HIV, and they actually ran all the resistance testing and reported patterns of the most common mutations that we see in these pregnant women. And what they found, mostly for NRTI mutations, women had an M184V and TAMS. Amongst NNRTI mutations, K103N was the most common, and for majority PI mutations, we saw M46 and I54V. So of course, naturally, if you have higher resistance, higher viremia, the natural next question is, do we have higher rates of vertical transmission? And fortunately, many folks have looked at this, and we can say that actually no. In the FACT-SMART cohort, they compared 232 pregnant women with perinatal HIV with 1,646 pregnant women with non-perinatal HIV and found still very low rates in both groups of vertical transmission. When you look at other countries and their reports on MTCT rates amongst pregnant women with perinatal HIV, it's very fortunate that we're still seeing rates somewhere between 0 to 1.7%. I'm going to switch topics just a little bit within the realm of maternal health in pregnancy and talk a little bit about the domain of psychosocial health. There's not a lot of data on this at all in perinatally infected pregnant women. Quite a bit of data in non-pregnant women, but very little in pregnant women with PHIV. This small study did report that there were no differences between perinatally and non-perinatally infected pregnant women when it came to mental health diagnoses in pregnancy or substance use in pregnancy. On the contrary, we actually took a look at our data and divided our cohort into 3 groups. We had 23 women who were pregnant women with perinatal HIV, 98 with non-perinatal HIV, and then 124 controls who were HIV uninfected. And we actually did find differences in tobacco use and illicit drug use, mostly showing that the pregnant women with non-perinatal HIV had higher rates of illicit drug use and tobacco use. But interestingly enough, what we also found is that depression during pregnancy was higher in the pregnant women with perinatal HIV infection when you compared it with the HIV uninfected women. When we did a pairwise comparison, though, probably due to the small sample size, we did not find a difference between the perinatally and non-perinatally infected pregnant women. But again, we had a small sample size. In multivariate analysis, though, when you compared against a control of the HIV uninfected women, both the pregnant women with perinatal HIV and the pregnant women with non-perinatal HIV had higher rates after adjusting for confounders of depression during pregnancy. So let's just recap a little bit about maternal health in pregnancy amongst these women. Women with PHIV have lower CD4s and higher viral loads compared to women with non-perinatal HIV during the pre-pregnancy, pregnancy, and postpartum period. Fortunately, vertical transmission rates are quite low. And lastly, evidence is pretty scant, and I think still yet very unclear as to whether maternal mental health or maternal depression in pregnancy is any different between perinatally infected and non-perinatally infected women. We're going to move along our spectrum of the pregnancy line here and talk a little bit about pregnancy outcomes and early infant outcomes to wrap up the data. So early studies, this one in Baltimore, have shown that women with perinatal infection have higher rates of undergoing therapeutic abortion. And this study demonstrated that the odds of having a therapeutic abortion was 6.5 times greater in an adolescent with perinatal HIV compared to an adolescent with non-perinatal HIV. And our colleagues from the UK actually reported similar findings of higher rates of termination in these perinatally infected women as well. But what's happening with the pregnancies that are not being terminated? You know, what are the pregnancy outcomes there? What I'm starting with here is just a smattering of a few of the larger case series across the world that have looked at these particular outcomes. And I think you can appreciate that the numbers are all over the place for preterm delivery, SGA, and low birth weight. What I want to say is that without a comparison group in these small case studies, it's really difficult to tease out whether there is a true association between maternal perinatal HIV and some of these adverse birth outcomes. So there is, fortunately, some newer and more recent data that has a comparison group and that does adjust for confounders. So we're going to go through a few of them right now. One of the earliest studies, published about 5 or 6 years ago, also out of New York City, was one where we looked at SGA birth weight outcomes and found that after adjusting for confounders, maternal perinatal infection was an independent predictor of SGA outcomes in the infants of these women. More recently, in some larger studies, for instance, our French colleagues from the French perinatal cohort have actually found no differences in overall rates of preterm delivery, SGA, maternal child transmission, or stillbirth. And it's important to note that this sample size was significantly larger than the smaller one in New York City. They had 64 pregnancies of women with perinatal infection and 1,500 or so pregnancies of women with non-perinatal HIV. Then our UK colleagues also found no differences in overall rates of preterm delivery or low birth weight. Their numbers also were a little higher. They had an N of 70 pregnancies in women with perinatal HIV and about 184 in their comparison group. And then lastly, again, probably the largest study out of the US is the FACS SMART and Impact 1025 combined analysis. We looked at the 3 outcomes of low birth weight, SGA, and preterm delivery. And the good news is we did not see an association between maternal perinatal infection and any of these birth weight outcomes. We did do an additional age stratified analysis. And I hesitate to show you this, but I think it may spark some interesting questions. So when we did this age stratified analysis, for preterm delivery and birth weight z-scores as well as SGA, we still didn't find an association between maternal perinatal infection and those birth outcomes, which is great news. However, in the low birth weight outcome, if you just look at the highest age group, which is these 23 to 30-year-olds, those would have been the oldest perinatally infected pregnant women that we had in the cohort. We did see a signal where maternal perinatal infection was associated with low birth weight. I want to just take a step back and make sure that we interpret this with caution, because as we all know, low birth weight can include either an infant with true intrauterine growth restriction, or also it could include a preterm infant that has a totally normal birth weight z-score. So despite this signal, though, I think it raises a couple of questions, because one of the things I have been thinking about is there something different about these women at the highest age group? Because effectively, these women have had HIV immunosuppression and perhaps immunosenescence for the longest. They're the oldest. They're also the ones who have survived the most. So there may be survivor bias. But what is, if anything, different about these oldest age group of perinatally infected pregnant women? So the last couple of studies I'll talk about will move on into the infants of these pregnant women, because I think that too is really important to consider as we think about mom-child dyads and not just silos of the mom and then the kid. So this is a study that we did a few years ago where we combined our data with a group in Baltimore at Johns Hopkins and evaluated the growth in the first year of life of infants born to perinatally infected versus non-perinatally infected pregnant women. And the blue line shows the trajectory of growth in the perinatally infected women. The red one above is the trajectory of growth in the infants born to non-perinatally infected women. And I think you can appreciate, at least in univariate analyses in these exploratory graphs, that length for age z-score was persistently lower throughout the first year of life in these infants born to mothers who had perinatal HIV. And when we adjusted for all confounders, when it was all said and done, we still saw this association between maternal perinatal infection and lower length for age z-scores throughout the first year of life. One other study that we did in our cohort was to look at infectious morbidity in the first year of life. And we defined infectious morbidity as hospitalizations due to an infectious cause within the first 12 months. We had 3 groups, infants that were HEU and born to perinatally infected moms, infants that were also HEU but born to non-perinatally infected moms, and then, of course, our control group of HUUs. And we found that infants of perinatally infected mothers had higher rates of ever being hospitalized for infectious causes in the first year. In final modeling, both the model with only the HEU infants and the model with HEU infants plus HUU infants, we still saw that association between maternal perinatal HIV status and increased infectious morbidity in their HEU infants. So, in conclusion, I think a couple of take-home points might be in order. One is, obviously, with the success of ART, girls with perinatal infection are surviving into childbearing age, resulting in increasing pregnancies in this population, which is, as Dr. Mandelbrot said, a wonderful thing. Pregnant women, though, with perinatal HIV have greater risk for immunosuppression, high viremia, and increased ART resistance in pregnancy, and that does pose a problem. They may or may not have higher mortality in the postpartum period, but at least in early studies out of New York State, they do seem to have worse survival during the postpartum period. The good news is that maternal PHIV does not appear to be associated with any of the big pregnancy outcomes, preterm delivery or poor birth weight outcomes, at least in North America and in Europe. And lastly, there is a real paucity of data regarding the long-term health and child outcomes of these children who are born to perinatally infected women. But some studies have started to point to a potential increased risk for early infectious morbidity or maybe poor growth. So I'd like to leave you guys with a few questions. We've talked a lot about data that's come out from North American and Europe-centric geographic location. While we understand that that's the case because of the way the pediatric HIV epidemic occurred, I think the next wave of perinatally infected pregnant women and their kids is going to come out of a geographic location that's completely different, mostly in sub-Saharan Africa or maybe Thailand. And we have to think about what will the impact of a resource-constrained setting with limited healthcare system infrastructure, what will that impact have on some of these outcomes that we've already looked at and felt comfortable that there's no association with maternal PHIV? How about the long-term postpartum health of women with perinatal HIV? And by long-term, I don't mean just 1 year postpartum, but what about 10, 20, 30 years out? Does anything in pregnancy impact the way in which chronic diseases, such as cardiovascular diseases or cardiometabolic risk factors, do they change or somehow act differently or behave differently because of lifelong immunosuppression and immunosenescence of these perinatally infected HIV women? And then lastly, what about the HEU kids of these women? And when I say the HEU kids, I appreciate that we have been talking about all HEU kids, but I'm talking about a specific subset here. The HEUs of women who are perinatally infected. Are they different? Or maybe they're not. Do they merit a different level of long-term surveillance or monitoring? Maybe, maybe not. I don't think we have enough data to say yes or no, but I pose the question because I think it's an interesting one to ask, as it may affect the way we do research and roll out programs. So I'll stop there and just thank you all for being patient and keeping your attention. Also want to thank our funders and supporters and this list of collaborators and mentors who've helped me through much of our analyses and research so far. Thank you.